This presentation deals with the medical and legal aspects of pain management. I shall attempt to explain the principle of balance, REMS, Risk Evaluation and Mitigation Strategy Program, mandatory education of prescribers about opioids, prescription requirements under the Controlled Substances Act, the illegal distribution of controlled substances, and pain malpractice issues. Pain management is governed by three types of interrelated policies, namely law, regulations, and guidelines. Laws and regulations have legal force. Guidelines do not. The purpose of pain management laws, regulations, and guidelines is twofold. First, drug control by law enforcement, which is aimed at preventing diversion and abuse of prescription medications. And secondly, drug availability to patients, which recognizes that many opioids and other controlled substances are necessary for pain relief and that governments must ensure their adequate availability for medical prescribing, dispensing, and scientific purposes. When both control and drug availability are appropriately recognized in public policy and implemented in everyday pain management practice, this is referred to as the principle of balance, or balanced approach. Review of pain management in the United States during the past 176 years reveals an imbalanced approach in favor of drug control. The availability of opioid prescription drugs to alleviate the pain and suffering of patients should be appropriately recognized in public policy and implemented safely in everyday pain management practice. With respect to the principle of balance in opioid therapy, government programs are intended to formalize ways to minimize the opioid risks while maintaining access for patients who need opioid medication. On the other hand, good medical practice requires physicians to maintain the balance of benefits and risks of opioids when treating patients. Most states have adopted by statute the pain management guidelines of the Federation of State Medical Boards, and several specific statutes deal with pain management, including assessment, treatment plan, consent, periodic review, intractable pain, consultations, referrals, and documentation in medical records. Physicians must comply with the law or confront dire consequences. In April 2011, the Obama administration unveiled a prescription drug abuse prevention plan which expands upon the administration's National Drug Control Strategy. The plan comprises four major action areas. First, education of the public and healthcare providers about the dangers and safe use of prescription drug abuse. Second, implementation of prescription drug monitoring programs in every state, share data across states, and have healthcare providers use them. Third, provide law enforcement agencies with support and the tools they need to expand their efforts to shut down pill mills and to stop doctor shoppers. And fourth, the development of consumer-friendly and environmentally responsible prescription drug disposal programs to limit the diversion of drugs. In 2007, the Food and Drug Administration Amendments Act gave the FDA the authority to require risk evaluation and mitigation strategy, REMS, as part of the ongoing evolution of managing risk. REMS programs are FDA-mandated requirements to minimize the risks associated with certain medications. An important part of the REMS program is the requirement that drug manufacturers thoroughly educate healthcare providers and the public about their drugs. A REMS program may be required by the manufacturer prior to approval of a drug or post-approval if new safety information becomes available or if it is determined that REMS is necessary to ensure that drug benefits outweigh risks. REMS can be mandated for any medication or class of medications. There are 5 different components for each drug REMS, but an individual program does not have to include all 5. Number 1, the medication guide, a communication plan, elements to assure safe use, and then the implementation and timetable for assessment. Components 1 and 3 are most relevant to prescribers. Component 1 provides educational tools to practitioners and patients. Component 3 includes special requirements or restrictions to optimize safe use of products. The third component, ETASU, element to assure safe use of a drug, may include training or certification of prescribers, training or certification of pharmacies or pharmacists, restrictions on where the drug is dispensed, evidence of patient use conditions, patient monitoring, and enrollment of patients in a registry. Between 2008 and 2011, a number of opioid REMS were approved for the drugs listed on this slide. The trade names are registered trademarks of the various companies. Let us turn to a class of opioids. Currently, transmucosal immediate release fentanyl, TIRF, drugs include Abstral, Actic, Fentora, Lazanda, and Onsolis from different manufacturers. Will the manufacturers be required to provide separate REMS for each and every product in this class of drugs? On December 12, 2011, the FDA approved the first single shared system REMS for the whole class of transmucosal immediate release fentanyl drugs. The TIRF REMS access program will replace the individual REMS for these agents. Therefore, the prescriber can enroll once for all of the products in the class and have one website and one set of information. Everything will be consistent, which allows prescribers and pharmacies to enroll into the single system with the aim of easing the burden on the healthcare providers. The TIRF class REMS program began in March 2012. Until that time, prescribers, patients, and pharmacies had to enroll in the individual REMS programs. The goals of the TIRF REMS program is to ensure patient access to drugs and mitigate the risk for misuse, abuse, addiction, overdose, and deaths from medical errors by prescribing and dispensing TIRF medicines only to appropriate patients who are opioid tolerant. Second, prevent inappropriate conversion of fentanyl. Third, prevent accidental exposure to children, and educate prescribers, pharmacists, and patients on the potential for misuse, abuse, addiction, and overdose. On January 26, 2012, the American Society of Addiction Medicine recommended that all health professionals who can prescribe scheduled medications must be included in an educational effort to improve patient outcomes and public health. ASAM approved the mandated prescriber education for all health professionals licensed to prescribe, dispense, or administer prescription drugs. ASAM stated, very few physicians are sufficiently educated about the potential psychiatric and addiction consequences of prescribing scheduled medications like opioid analgesics and sedative hypnotics. To get ready for REMS, the prescribers should coordinate efforts by the office, clinic, and pharmacy by reviewing current standard operating procedures and staff roles to prepare for more interaction with staff, patients, and pharmacists, and for the potential for new documentation requirements with REMS. And one must ensure that he or she understand the federal and state regulations on prescribing opioids. REMS are an addition to, not a replacement for, federal and state regulation. It is worth repeating that under the Federal Controlled Substances Act of 1970, a prescription for a controlled substance to be effective must be issued for a legitimate medical purpose by an individual licensed practitioner acting in the usual course of his or her professional practice. A corresponding responsibility rests with the pharmacist who fills the prescription. The DEA does not define nor regulate medical practice standards. No federal laws or regulations put limits on the quantity of controlled substances that may be prescribed, but some states or insurance providers may limit the quantities of controlled substances prescribed or dispensed. The Controlled Substances Act and the Code of Federal Regulation acknowledge that controlled substances have useful and legitimate medical purposes, and practitioners are not limited in their ability to prescribe, administer, or dispense narcotics to persons with intractable pain. In 2006, the DEA reiterated its policy to prevent abuse and diversion without adversely impacting the legitimate need of patients to have full access to pain relief prescribed by their physician. The DEA also reassured physicians that it does not apply a greater scrutiny to the prescribing of controlled substances to treat pain. Effective June 2010, DEA regulations provide practitioners with the option of writing prescriptions for controlled substances electronically. However, electronic prescriptions are subject to processes and procedures including initial identity certification, two-factor authentication, the use of HHS transmission standards, and no alteration of prescription during transmission. Now let's turn to illegal distribution of controlled substances. The necessary elements for a charge of illegal distribution are the defendant knowingly and intentionally distributed a controlled substance, and secondly, distributed or dispensed the controlled substance not in the usual course of professional practice and not for a legitimate medical purpose. What about motive? A malicious motive or greed are not required to convict a practitioner under federal law. The federal government takes the position that the physician's documentation, and therefore the legitimate medical purpose for prescribing and treating, should be evaluated in view of the doctor's overall approach and thoroughness, not on one incident where the doctor may have a bad day or lost dictation or some other reasonable situation. As to privacy and security, controlled substances must be maintained in a safe or a steel cabinet. Prescription pads should be maintained in a secure locked cabinet. Access to controlled drugs and records should be limited, and prescribers should conduct background checks on their personnel. The DEA registration requires the reporting of theft and loss, destruction of drugs, modification of registration, address changes, and on renewal application one must not misrepresent or lie about anything. The major problems that doctors confront with respect to controlled substances are doctor shoppers, forged prescriptions, excessive or unauthorized prescribing, unauthorized purchasing, and internet prescribing. When government agents investigate medical records to spot patients who are doctor shoppers, they look for a number of red flags. First, the symptoms are incompatible with the reported injury. The patient visits the physician some distance from home. There is a history of problems, but no medical records to substantiate the history. The patient has multiple accidents, insists on drug of choice, claims loss of prescription or loss of medications, fails to provide or go for medical testing, and furthermore, other doctor shopper red flags include taking more medications than directed, requesting medications early, using medications from multiple physicians, which can be spotted in the prescription drug monitoring program, uses medications prescribed for others, or uses medications in combination with alcohol, and fills prescriptions at multiple pharmacies. What about doctors? When investigating doctors or prescribers, government agents look for indicators of diversion of controlled substances, and those include prescribing inordinately large quantity of controlled substances, issuing large numbers of prescriptions or writing more than one prescription on occasions in order to spread them out, medical records that lack physical examination and follow-up, physician warning the patient to fill prescriptions at different drug stores, physician issuing prescriptions to a patient who is known to be delivering the drug to others, physician prescribed controlled substances at intervals inconsistent with legitimate medical treatment, or there was no logical relationship between the drugs prescribed and the treatment of the condition allegedly existed. Physicians who use street language, slang, rather than medical terminology for the drugs prescribed may be suspect. Let's give some examples. Here is a new patient who went to a doctor with the chief complaint, "I need pain medications." The doctor prescribed Dilaudid, 4 milligrams, 240, plus Xanax. The records showed poor physical exam, no history, no recent old records, no thought process, and no diagnosis. Here's another patient. During an office visit, the patient complained of back pain. The doctor prescribed Schedule II controlled substances, but there was no documentation of an exam of the back, no old records, no diagnosis, and no thought process. Another patient at an initial visit complained of back pain from previous back surgery. The doctor noted, "I do not have his surgical records." Under exam, he wrote, "Decreased range of motion at lumbar spine. Treatment, OxyContin 80 milligrams 4 times daily plus Lortab 10 milligrams 4 times daily." This patient is getting a prescription for only oxycodone. On a drug screen test, the toxicology results were negative for oxycodone, but they were positive for hydrocodone, hydromorphone, cocaine, and marijuana metabolites. This next patient, the doctor's complete notes were the medications only and nothing else. The doctor started the patient on OxyContin in increasing doses beginning at half a tablet 3 times daily, 20 milligram size, and increasing the dose to 80 milligram tablets 6 times per day. He saw the patient at intervals of 3 months without examination. There was no record of pain relief. The doctor prescribed also roxicodone, 15 milligrams, 100 per month, and alternated the date of prescriptions. And this last patient received dilaudid, 4 milligrams, 240, and the record showed no address, no date. Medication was given PRN as needed. There was no legitimate purpose noted, and it is interesting to note that the street value of this treatment is over $7,000. What's the doctor to do to comply? Physicians should document legitimate reason for prescribing, analysis of all medical records, adequate history and physical exam, history of drug abuse or crime, supporting tests such as X-rays, MRIs, or CT scans, continued reevaluation of pain relief, and functional improvement and quality of life. Also document the treatment plan and the patient compliance with the treatment. Physicians should also document the amount of controlled substances prescribed, the amounts used since the last visit, the amount of dosage remaining, time intervals since last visit, especially if it's early, amount of pain relief, improvement in function and quality of life, and evidence of abuse or diversion if noted by the doctor. Other recommendations for the doctors: they should sign a pain management contract, conduct pill counts, conduct surprise drug testing, use prescription monitoring database, adhere to the Medical and Osteopathic Board and Medical Society's pain management guidelines and policies. Finally, let's talk about medical malpractice. Pain malpractice is increasingly common. The causes of the malpractice suits generally include no treatment for pain, under-treatment, over-treatment, continued ineffective treatment, lack of informed consent about alternative therapies, addiction to opioids, wrongful deaths from overdose, and failure to consult or refer to a specialist. We must remember that the doctor has a number of duties to consider, including, among others, the duty to establish a physician-patient relationship, the informed consent or refusal, the duty to provide a pain management agreement, the duty to document in medical records, the duty to treat appropriately, the duty to refer or consult to a pain specialist or psychiatrist, the duty to accurately code for diagnosis, testing, and treatment, and the HIPAA privacy and security standard. And we should remember the other legal considerations, the DEA standard of care, the mandatory education involving the FDA REMS programs, managing a difficult physician-patient relationship, and being alert to aberrant patient behavior, and finally, terminating a physician-patient relationship and discharging a non-compliant patient. Thank you.